afternoon. My name's Anna Fenton. I'm the current co-editor-in-chief of Climacteric, and today's session covers the role of unique hormone therapies and progestogenic agents, as well as the role of non-hormonal therapies in managing menopausal symptoms. So it is important when we're prescribing hormone therapy to treat each patient as an individual and therefore individualise our choice of hormone therapy. So we have choices with estrogen with regard to dose, method of delivery, and with the progestogens, we need to think very carefully about how they interact with various receptors, as that determines the balance of risks and benefits. So for instance, today we've talked about dydrogesterone, which is a retroisomer of progesterone and acts in a very similar way with rather neutral effects on metabolic and cardiovascular parameters. It appears, based on 3 very large observational databases, to be associated with a lower risk of breast cancer compared to some of the synthetic progestins. We see this in the French E3N study, the Finnish breast cancer registry data, and also the UK GP database. Drospirenone is an additional, quite unique progestogen, which has both anti-androgen and anti-mineralocorticoid effect. This allows us to interact potentially with blood pressure, body weight, and have effects to treat acne and hirsutism. Tibolone is a very unique hormone product, which is a derivative of 19-nortestosterone. This has effects to improve bone density and reduce fracture risk, but at the same time is not an ideal option in those who have metabolic risks, risks for stroke, or who are breast cancer survivors. Now, for many of our patients, they will be looking preferably to use a non-hormonal therapy to manage menopausal symptoms. And whilst there is an enormous array of products available, becoming aware of the evidence behind these products is really important in making a choice. The options essentially boil down to looking at one of the SSRI or SNRI antidepressants, perhaps using gabapentin or pregabalin, or perhaps looking at stellate ganglion blockade as a backup option. We have small-scale clinical trial data with a range of other medications, including clonidine, cetirizine, mirtazapine, and meclobamide, all of which may show some promise in specific patients. So I think what I would like you to be aware is that we do have a range of therapeutic options, and it is important in this situation to deal with each individual patient's requirements and tailor your regime to what they need. I would also suggest you use as a valuable resource the IMS video series, because that summarises very nicely many of the things we'll talk about today. Thank you.